Good afternoon. This is Erin with the Department of Medicaid. It's not quite 2 o'clock and we're still clearing the waiting room. We'll give it just a few moments before we get started.
Hello.
Good afternoon.
How are you doing? I think about that time.
It is. I have one till and we're still clearing the waiting room, so we'll give it
Uh,
just a second. I do currently
Perfect.
show yourself, Dr. Kalasa, and Dr. Braun on. If I missed any other TAC members, please let me know.
Uh,
I
Dr.
see it.
Patel, I don't think will be here, but we'll
Okay.
we'll need to check and watch for that.
I see a Joe coming out of the waiting room, so that might be Dr. Petrie. It is 2 o'clock and your waiting room is clear. You do have a quorum, so I will turn it over to you.
Thank you so much. Uh, so I believe you did say we have a quorum and we have taken roll
Yes,
officially. Okay, you did get that.
I
Perfect.
see Joe is Dr. Petrie.
All right, perfect. There's Dr. Petrie. I see him up there. And Dr. Kalasa, I believe you said is on here somewhere for some reason. I haven't seen him.
I'm here.
Oh, okay. There he is. Right there. There. I saw him. All right. So this is TAC meeting for 8/8/2025. Quorum's established. I guess first is to approve minutes from TAC meeting on 5/9/2025. Is there a motion to accept
To
those
approve.
minutes? Dr. Petrie, you made the, I
Make a
believe, a
motion to
motion.
accept the minutes.
Okay.
Yes. Yeah.
Any second?
Second.
Second, Dr. Braun. Move the minutes to be accepted as noted. Um, does anybody else from the have anything to address to the TAC committee? Any questions from any representatives or anything from MCOs, Medicaid, anybody who is on the meeting? Any questions or anything they need to address to the TAC members? Hearing none, I move to old business. The only thing I had noted in old business was point of care testing, which we added to new biz carry over to new business. Is there any other old business that anyone has that will need to be addressed before moving on? Okay, hearing none, we'll move to new business. Uh, and if we can, I'd like to start. Sorry if I'm looking away. I have about two computers open in front of me with notes and things like that. So if we'd like to move to new business, can we move to discussion of the point of care testing codes? And I know placements of intraoral medicaments and dressings. Uh, Dr. Kalasa, I believe you had multiple questions on that. Do you care to?
Sure. The biggest thing that we're running into, and when speaking with oral surgeons specifically, is you're talking about standard of care. So when diabetic patients come in, they need sedation, anesthesia for extractions, or whatever the case may be. It's the standard of care for all insurances, private pay, no different. That you obtain a glucose. You can outsource other tests. I think it makes a lot. Testing is not efficient for the patient or for the healthcare systems. We would just like to see it considered that those be, if there is a time component, there is a component toward buying the strips.
I think I just lost Dr. Colasa there. Uh,
Sorry, I dropped out there. What did you guys hear to?
I had heard to the glucose, and then it started cutting in and out. Um,
Okay. Is this better now? I think I'm in a
yeah, it
better
is.
spot.
Thank you, sir. It is.
Yeah, so point of care glucose testing on diabetic patients is standard of care. All other insurances and private pay, obviously, that gets billed. A lot of times these tests require maintenance of the machines well as buying the strips themselves. It is a standard of care to do a glucose test before anesthesia, and a lot of times after anesthesia, especially if you have to modify that, give some insulin or give some glucose. We would just like to see that code covered. Um, the other point of that is I put the codes in the chat. Is we're having to use a lot more additional medicaments inside the socket as our population gets sicker. You get more people on antiplatelet therapy as well as anticoagulation therapy, and you're seeing a large uptick in that. We're seeing a large uptick in that, and those things do have a cost. I'd be fine with capping the number of those you could do, obviously, but again, it's just an additional cost that we're having to incur when we're taking care of these sicker patients. And so that was kind of the request.
Any questions for Dr. Colasa on that and point of care testing? And I know another one, which I don't think we noted. I mean, we talked more about glucose, but I know, of course, with sedations, pregnancy is another one that goes into it. Of course, glucose INRs.
Sure, and there was some, we talked about some certain things to be required to be a lab, and so I wasn't really trying to make this overly difficult or to try to, it's mostly just to recoup the cost that we incur for the more common things like pregnancy test or a glucose test. I'm not looking to get into the weeds on whether we qualify as a lab for INR
Okay.
to do that officially. I just don't think that's what the goal of the oral surgeons is. It's mostly just to recoup some of those materials and time that we have to put in when we're managing these patients, specifically materials for going into the socket, and then just a lot of, like you said, potentially pregnant age females, and we have a lot of diabetics too that require multiple tests. But I would like to at least be able to bill for one to recoup some of that cost and time. It's basically practicing at the standard of care, I guess. And so that's where the question is.
And that is something you see at surgery centers. You see if you're taking the surgery center, any kind of outpatient surgeries, you're right. I mean, that's just standard. You're going to have a glucose test. You're going to have pregnancy test on any childbearing female of that childbearing age. So that is sticking with truly standard of care. Do we have any comments or any recommendations from any of the MCOs or anything on how that?
BJ, you have a
Yeah.
hand up from Dr. Rich.
Oh, Dr. Rich. Sorry.
Hey, yeah, good afternoon. Can you hear me?
Yes, I can, sir.
So happy to try to work with you guys with the surgeon or the general dentist, whoever's performing the test to craft a way to um compensate appropriately. But I think really my suggestion, and I don't know if Justin's on the meeting or not, but would be to see if the state would be willing to add a code to the fee schedule that would cover these. We could do it in a like a 9 series code. That there's probably one already there. And just add that code and specifically define what it's used for and when it should be used. And then that makes it really simple for the MCO to add it to the fee schedule and cover it. Otherwise, we could try to incorporate it into something else. But that can get a little bit um, gray. Get a little gray area when the code doesn't really uh, isn't exactly applicable to what you're doing. So that would be my suggestion, that for the group is to pick, determine what code best fits the need from the CDT book, and then request and see if DMS would be willing to add that. They've been pretty good about adding procedure codes when they're indicated. So
Thank
Hey,
you.
Adam.
yes, sir.
I would just put them in the chat. There's two pretty good codes already that exist: point of care glucose with the D code, and then also
Right.
with the coagulation. It's basically all these patients are on. There's so many now on. It's not the antiplatelet stuff that I use it for. I know some people are more aggressive with it. It's the Eliquis Xarelto Coumadin patients. Uh, and yeah, I would even be fine. It's basically just a recoup cost. If we could limit it, one per quadrant for that, and then just one glucose test. Like I'll do multiple a lot of times, inter-op if it's longer, post-op just to make sure. But something to just say one per surgical visit, or then one per quadrant if you're doing a lot of teeth. Just basically something to at least break even with utilization of those materials.
Right.
So
Dr. Cottle has his
Doctor,
hand
okay,
raised.
Dr. Cottle.
I was just going to mention that in the past, Avisus did a pilot project where we did in-office A1C testing, and just need everybody to be aware when you start doing in-office testing, you have to get a CLIA waiver. The state of Kentucky did give us a special dispensation to not have to go through all that for the pilot project, but anybody that's going to be doing it on an ongoing basis has to get that in place.
So you don't need a CLIA waiver for the point of care glucose, and that's why A1C is different, INR is
Right,
different.
right,
Yeah,
and that's what I'm talking about. Some of these, because you were talking about other labs, and I'm just saying the A1C does require a waiver.
sure. And those we can outsource, even though those I think everybody's fine to still outsource those to the hospital or the lab just to not make this more complicated. But as far as like immediate bedside stuff that we have to do on the day of surgery, I would love to take my patient's word for it on their blood sugar, but I simply can't because that's not the standard of care. Um, and so just to have some recoupment of those costs, and same thing with managing sockets that bleed after on these patients with and we could even make it a mandate they have to be on uh, dual antiplatelet or a DOAC, one of the anticoagulants. I mean, we're fine with the restrictions. I'm trying to make sure it doesn't get overutilized, but just to recoup the cost when it's absolutely indicated. So thank you guys.
Justin Derringer has his hand raised.
Mr. Derringer.
Thank you all. So we do actually have three codes that we're looking at. We have D7922 for the intrasocket dressing. We have D0411 and D0412 for point of care testing. So we've got those three codes that we've done some research on. We've looked at some other states to see what they're covering, how much they're paying, some of the
differences between what they're doing. We did find a couple of states out of the ones that we looked at that covered the intrasocket dressing. We did not, well, we actually did find one state that was covering DO 412 out of all the ones we looked at. The rest did not cover that. But one of the other things that we kind of ran into was with our other surgeries that those the point of care testing was something that was kind of built into the fees structure when they were originally put on the fee schedule when you build some of those other non-codes. So trying to kind of parse that out and look at the differences in other surgeries versus oral surgeries, and how those non-code rates were put together. So that's kind of where we're at right now with that research. Just trying to be as transparent as we can be in our process with you all. And then at the same time, we were doing our fiscal analysis on what type of fiscal impact that will be. As you all probably are aware, we did not receive an increase in funding in the last budget session. There was a small amount of money, I think, set aside, and the Legislative Research Commission was to determine where that went. They sent that back to the budget, so we did not receive any of that. There's really no, we don't have any funding for anything that would have a fiscal impact, and I'm going to assume the addition of these codes would. But once we get that fiscal impact written up, we'll put all of our research kind of together. Once we get all that parceled out, and we will send that up to leadership. So still working on it. We've done all the research as far as what states are covering, how much they're covering, and whether it's built into other rates in their fee schedules. And right now we're just kind of trying to finalize all that. But that's where we're at, and I'll have a hopefully much more or more advanced news on our next meeting.
Thank you, Justin.
You're welcome.
Let me make one more pitch. If you look at our the health of our population, as far as those on AFib and those with diabetes, that would be my last little pitch.
Yeah, we'll definitely keep that in consideration, and the fact that Kentucky is a state that struggles with diabetes dramatically. Absolutely.
Moving on to new business topics, I think is that closed, I believe, right now. I think that's everything.
I'm good.
Need to be addressed on that. Continuing on new business topics, and this is one I have reached out after I found out to several of the pediatric and other oral surgeons as well. But we have seen several talking to have issues more with sedation denials. And that's from everything from, it sounds like pedo to oral surgery to even general dentists that offer sedation options. My understanding, most are being involved with MCOs more so than traditional, I guess you would view as traditional Medicaid, old Medicaid, however you want to say it. I don't know all the ins and outs of those sedation denials. I know Avisus does have their scorecard sheet when they look at doing having to do a case in the OR, something like that, requiring general anesthesia. I'm not sure exactly what denials are getting met. Does anybody else have any information on the denials that are being seen across the board?
I can speak to it a little bit, and I had a lot of people contact me when it started. It was mostly just that there was a deviation in what we had all been doing from a couple of one of the MCOs, a couple of the providers, and sometimes the denials still fell within the scope of what we were supposed to do. I think that has been rectified to the best of my knowledge, and Jerry can probably elaborate on that. And I think the issue was just a drastic change that was rectified. to the best of my knowledge.
That's correct. We consulted with multiple oral surgeons across the state, including Dr. Plaza and Dr. Street and Dr. Wagner and some others, and came to a meeting of the minds. And I think, to my knowledge, everybody's happy now.
Okay. I just knew I'd gotten several hits from all of a sudden, and then I haven't quite heard anything about it recently. So I wanted to bring that back up because I promised I would bring that up to find out more information. And this is one that I have had people question, especially now with it seems like there has been some changes with some of the MCOs, is provider networks and how provider networks are determined. I know, like in my practice, we have multiple providers, but we only have one provider in an office during a day period. So technically there is only one provider. However, you may have multiple providers listed within an office. So you still really only have one provider seeing patients, but yet when you look at provider networks, there could be multiple providers listed in that office, which kind of could arguably skew provider networks. Are people having satellite offices? How is that evaluated in those cases by the MCOs in determining provider network, and who's in charge of determining adequate provider networks? Is that a state determination or is that an MCO determination?
Chelsea, is that something you can answer? I think I saw her on.
Most things I've seen or read just talk about having a provider network.
This is Angie Parker, Director of
Hello.
Quality and Population Health. Hi.
Hello.
What are you needing to know specifically? I'm sorry.
Well, one thing we're seeing is a lot of times provider networks. So when you look at maybe number of dentists in a county that are on network, may actually not be as representative of provider networks as you would think. Yeah, because you could end up having 6 providers, but it's all in a group. An example could be some government clinics like FQHCs. Well, they may have providers that cover, so they have to be listed in that facility, but yet they really work at a facility 2 counties over, but yet they're listed in all facilities. Or you have a satellite office in a location and you're listed at both in that county, but yet you're only there 1 day a week. Or you have an office with multiple providers that split time between 2 offices, but yet they're both listed. So it looks like 2 providers when really there's only 1 based in that location.
And Dr. Millay, we've been trying to evaluate what all of those dental networks really look like. And technically speaking, we have allowed if a provider is at a particular office for at least 2 days, they can be counted as in the network adequacy. We also know that there are challenges with our Medicaid patients that the providers may not even see Medicaid patients, but they're still listed, or only see certain ages, or, you know, a lot of challenges within the dental provider network. We are working on a report with the managed care organizations for providers who have not billed a claim within the past year to see what the issues are, so that we can make sure that what they are counting as an adequate network is truly adequate.
Okay. But you said two days a week is kind of what the judgment is on determining a provider, I guess you would say.
That's really not, and that's really not what we would like for it to be. But obviously, we do know with the challenges with having enough dentists in the state, and that dentists can travel from, to your point, a county over or whatever, but they should just be counted where they see patients.
Correct. And that's kind of what I was looking at, because like I said, I know oftentimes, especially when you have offices in other counties, you may go cover So
Mhm.
you have to be listed, but it's not really there. You're listed more as a coverage provider. And I believe Miss Hensel has her hand.
Yes, she's with United.
I
Okay.
do. It's Krista Hensel. I'm the CEO for our United Healthcare plan. So I can't speak to all organizations, but definitely from a United Healthcare dental perspective. And I think Dr. Rich is on the line today. If you see something incorrect listed in the directory for your practice, please, please, please let us know. It's our we really want to make sure that our provider directory is an accurate representation because it causes a lot of angst for members. It causes a lot of angst for our member services and community health worker teams as well when we're trying to help make appointments. So if you see something inaccurate, please work with your provider service representative, provider advocate from UHC Dental so we can make sure and get the best up-to-date roster data for your practice.
Or call me or
Yeah, or
email me.
call or email Dr.
Call Dr.
Rich.
Rich. Call
Yeah.
Dr. Rich.
I was
Keep it
trying
easy.
not to tell him that, Dr. Rich.
That's all right.
I
That's
get in
what I'm here
trouble
for.
for telling people that all
Dr.
the
Rich has
time.
always been very open about that. And we always appreciate that. Um, any other information on provider networks or
Just a
questions?
comment on that, BJ, and on the provider network itself. One clear issue that I get calls on repeatedly is the network that is in place and the practitioners that are in essentially dental deserts, except for their practice. We have networks that seem adequate, and we have networks that show multiple providers, but many of those providers are not accepting new patients or are so booked out that they simply can't see enough patients to cover the patient load. So the provider network may look healthy, but when it's 9 months, 10 months, some in cases a year to get in for restorative, for oral surgery, for critical need, then that's not a network. The problem then becomes those practitioners where I get the call is they are getting notices stating that their wait time is too long for a patient to get in. Now, emergent care is a different thing, but non-emergent care, their wait time is too long for patients. I'm not sure what practitioners are to do when there's an inadequate network and they are seeing all the cases that they can see, and yet there's patients that have nowhere else to go but to their office. Now, obviously, a fix is build a bigger office, hire more dentists. We can go back to our discussion on the break-even point on an option for these practices to do so. So I always grow concerned when really good practitioners that are doing great work and are really trying to see this population are reprimanded when there is nowhere else for these patients to go. And those patients aren't getting adequate care simply because the network is not as robust as what appears on paper or we're told is on paper.
And a lot of that even goes into one of the other topics, which I kind of had. It would be jumping around to the next, which kind of parallels that when you're looking at continuation of care, because patients end up getting moved to additional MCOs, which may not be in network or in network, and then you have continuation of benefits. I mean, I've seen everything from the patient comes in, they're on one MCO, they get treatment planned, you're starting to plan restorative before they ever come to their first appointment. All of a sudden they've moved to a different MCO that maybe you're not a provider in network on. And it's like, well, we're sorry, we can't see you now. You're going to have to try to find a new provider because we're not in network with that one. and keeping that continuity of care. And it's not as easy as just saying, hey, sign up for other MCOs.
Yes, and
Similarly,
I would add, this is Angie again with Medicaid. If there's an authorization in place with one MCO and they change MCOs, and that they're not in say for you example, and you don't have that MCO in which they currently have, an authorization for those services are transferred to the new MCO. They get that information and they're supposed to allow any authorization that was in place with the transition. Now, with that said, they could potentially try to move that patient to an in-network provider, but they should be working with you on getting those, whether or not it's a letter of agreement or some sort of thing, because you are a provider of Medicaid, you're just not within that
network.
It looks like Dr. Rich has
his hand up.
And sorry, it took me a second to get off mute. Yeah, so I just was going to say much similar to what Ms. Parker said, but when we get a new member, obviously the prior auth is transferred whatever was to us. But in addition to that, they're in a TOC network. We'll put them in a TOC network for 90 days where they have the ability to see out of network providers, and we can work with you or whoever. So they can always see that out of network provider, and we can pay you in that transition of care period. For that, it's really more about the provider agreeing to see the member, but for continuity of care and continuation care with that, obviously the state and UHC thinks important, and we're contractually obligated to do that. That's what those provisions are there for. So, but I understand. I don't think that's very well known or
no, I mean,
in
I've
the
been
provider
a Medicaid
community.
provider for ever since I've been in practice, and I've never heard of that, Dr. Rich. So this is totally new to me. Is that something we need to contact you directly, the MCOs directly regarding? Because most of the time this is not necessarily in general dentistry a pre-authorized aspect. It's more, hey, look, you've been treatment planned. You're not pre-authorizing,
right? Sure.
10 fillings,
but
and the cleaning.
In our system, a new member in our plan should have 90 days of a TOC network, regardless of where they came from. So that would be any Medicaid provider could provide care for them, and it would be covered.
And on billing that, I guess you would have to have access to UHC portal if you were, say, not a UHC provider.
Yes, but you would, if you our hub is we're not the only one who uses that hub platform. So if you're already using the hub for any other insurance carrier, it's an easy conversion, easy to add. But you could always submit a paper claim.
Okay, so paper can't always be submitted.
Hate to say that, but yeah.
And I think Dr. Rich, you're always trying to be involved in those as well, just in terms of trying to continue to build out the network. If there's a patient base and there's mutual interest, which there's definitely interest on our side, we welcome those conversations. And that's kind of how we see those opportunities as well, as leverage those member moments to continue to build the network the members are seeking out.
And I guess, Dr. Cottle, I'm not trying to put you on the spot for anything, but I guess Avisus has a similar type process.
Yes, absolutely. We honor prior authorizations that were issued by the previous MCO.
Okay.
No problem there. Absolutely.
All right. And Dr. Petrie, I know, of course, with ortho, that's a much bigger deal because it's a longer term treatment option. Do you have any questions or additional comments running into that?
Well, yeah, some of the point of this working with Dr. Rich in the past week with some UHC aspects of it has been resolved. And in our practice, my hope is that that's been resolved in all of the ortho practices that were struggling with a continuation of care coverage in the new network. That being said, too, though, with more patients moving around with the changes that are certainly coming, and moving around to the SkyGen and other setups that are different than what a lot of practitioners are currently accepting, I have great concern, not only for ortho, which certainly is a big one because patients are in care when you're billing for the final third and then on into records, but in anything that's been pre-authorized, so that practices can be covered. Dr. Rich, has that resolution to the final third been resolved in other practices or just our own?
So it should be resolved in all of them, but we have treated a lot of them as one-offs as well, just because when the original Anthem prior auth information came over, it came in one huge dump, and it was not picked up. It kind of got picked up in pieces. So, and I'm not an IT guy, so I can't explain it all. And then followed by that, so we have the authorizations in the system, but it was kind of a little bit on these ortho cards, quite honestly, a learning curve, because it was the prior authorization we see didn't really look like the prior authorization, that it didn't mirror what the system would normally look for. So it said there's one here, but I can't really cross them together. So those issues have been ironed out. It was, like I said, it was a little bit of a learning curve for everybody when you saw it on that kind of scale. But certainly, if any claim is, and when we should be getting close to the Anthem membership, at least, because it was, that 6-month visit should come up where we pay that second payment, should be about hashed out by now. But in the event it has, if there's any of them, I always have to take a look and make sure those get corrected and adjusted. But that I think that's enough of a background on what happened there. My apologies.
No apology, Nina. I was just glad how quickly you got that resolved once it was clear. So thank you for getting that done. On a similar aspect, we still, and I'm not sure how many practices it impacts, but it certainly impacts ours. With the Aetna switch going back, we're going back multiple years. And I know that we spoke on this in these TACs and with Commissioner Lee, Dr. Cottle. We've corresponded a few times, and we're still looking for a resolution for the cases that the fee change to be more front end loaded in ortho, and then the back end fee was leaving practitioners without the full payment of their fee. I'm not sure how many practices that affected. I know in our practice it was 187 patients. I know with the Aetna fee, if the full fee had been paid, that difference, which was an $83 difference, that difference was over $15,000. In our practice, what we've requested for the last few years is for a resolution of that, just the $13 that was left out of what would been the original fee, the lower fee. But that's still looking at almost $3,000 when you're looking at 187 patients. And again, that is just our practice. I don't know across the state how many patients that affected. I still am trying to understand what we need to do to resolve this. If you could comment for our practice and all.
from what you're talking about, you texted me the other day about that, and I forwarded that to one of our directors in the department that handles that, and he's already pushing it through to get that resolved for you. So it'll be a done deal shortly for you.
Great. Thank you very much. Are there any other practices that are in that situation still, or have all those been resolved, or will all those be resolved?
I think anybody that has brought it up to me, yeah, because as you know, I give my cell phone and email to every dentist in the state, and I have for 13 years. So if anybody else, if you know of anybody else that has similar issues that haven't been resolved yet, have them contact me and I'll get it fixed, just like I'm having yours fixed right now.
Thank you. And I appreciate your prompt response on that.
Any other questions on, and I thank you guys for helping on the provider networks, and I believe the state working on their research on doing that will be a huge help moving forward. And I know anybody who I'll keep emails out to. I know several heavy, I guess, providers to make sure their information is up to date as well, to review to make sure everything's the best representation. That, and one other thing in there we have in new business, and this is one I was curious because I know last time I was given a page to look at the MCOs with direct contracts. One thing I didn't notice was Avisus and DentaQuest. Do they have direct contracts, or is that listed through the parent MCOs in direct contracts? The website I was given just to review a couple of things, I did not see an Avisus or DentaQuest contract. So I did not know how those were set up.
Hi, this is Kim Gray from Avisus. We have direct contracts with Humana and WellCare.
Okay, but that's not direct contract with the state.
I'm sorry, it's Aetna and WellCare.
Yes,
I'm sorry.
But that's not a direct contract with the state. So that is
correct.
Okay. And that's what I was looking when I was looking at the contracts that the state had issued. I did not see one for Avisus and DentaQuest. I don't know if there's a representative from DentaQuest on here who might be able to comment.
Yes, this is, oh, I'm sorry.
Oh, go ahead.
No, this is Shannon Horgan from DentaQuest. Same, we do not have a direct contract with the state.
Okay. Okay. And that was my point on that. Does the state see those subcontracts, or is that in-house, I guess you would say, or does the state have a stipulation on subcontractors within that?
Hey, good afternoon. This is Chelsea AG here. I work in the contract monitoring branch. So yes, so we review any subcontractor that signs on with an MCO. The state is responsible for reviewing those prior to their inception. And if you actually, just for your awareness, if you want to look at what some of those requirements are for the subcontractors, they're in our actual MCO DMS contract that's on our website. You just go to the subcontract section and it will give you all the details of what the requirements are for the subcontractors to be approved.
Okay, and that's where I was needing to go then. That is, thank you for that, because that's where I was having issues trying to find anything on subcontracting.
Yeah, absolutely.
Okay. Is there any other new business that needs to be addressed right now, or anything that we need to go back to?
I will have some information, BJ, I'm sorry. I'll have some information from the MOAB and our discussions there. not the least of which that we really have not addressed dentistry yet, but some global things that will be impactful from the big beautiful bill will include eligibility reaffirmation every 6 months, which is going to be impacting, as well as for the expanded population, the work requirements. It's yet to see where aspects of a copay, as that is back in discussion again, will go. But as we've seen in dentistry, it's really a payment that is unable to be collected, and is a barrier to care. But those were discussions we can have more probably at our next TAC meeting, where I think more will have happened in the MOAB as it relates to dentistry. Beyond that, since we have our agenda, I've had a number of contacts about providers having recoupments, and specifically recoupments on patients that at the date of service, they have screenshots of the eligibility and being able to demonstrate that. And yet when post recoupment, being told that the patient should not have been shown eligible, so the service should not have been performed, and so the payment is being recouped. That we've had this before and we moved past it. It seems to be happening again, even when providers are going to not only the MCO websites, but going to the state website to show eligibility on that day. This is a major challenge, especially for, say, our oral surgeons who are taking out third molars, and to then have that recoupment. These are not patients that we're able to go back and collect fees from. And someone like Dr. Colasa is very in a bind, where they have done the work, done good work, and then see the underpaid already fee recouped to not even cover the cost of the treatment, where they did everything they could do to show the eligibility, to determine the eligibility, and to know the eligibility. And it's just, it's an unfair way of doing business. I wanted to just have a discussion on that.
Yeah. And that's crucial in all aspects of Medicaid. You're correct, because that is we rely on that information, and I thought that issue was resolved. So this is first I'm hearing of it. Please, anyone to comment?
Hi, this is Chelsea AG again. Just wanted to quickly touch on at least one area that might be driving some of this, which is retroactive SSI issuance. We did earlier this year, as we started getting kind of an influx of concerns from providers that this was happening, we did determined that there needed to be a change in our system, the DMS system, to not have these retroactive changes happening in this way. And you'll have to forgive me, I'm not the eligibility and enrollment expert. Jordan Griffin would be the expert in that. But what we did with our MCO partners is we had issued guidance in April that if there was a recoupment that was tied to retroactive SSI issuance, that we asked them to cease recoupment for those particular cases. And we do have some guidance that our eligibility enrollment team recently developed for providers. If you do find yourself with a recoupment notice. And I can share that with Erin, so she can share that with you all, because it's kind of a step-by-step of what you need to do if you get one of these recoupment notices. That is what we're doing in the meantime until our system update occurs. I believe that should be happening at the end of this month or in September, if I'm not mistaken. But for those any other eligibility changes that are not tied to SSI, I wouldn't be able to speak to. Jordan would have more information about those types of eligibility changes if they were retroactive. But specifically for SSI, we saw that was an issue. We're making the changes in the system to rectify that. And we're working with MCO partners to make sure that providers are made whole if that is the reason that the eligibility changed. So again, I can share this document and that will give providers a step-by-step on what you all need to do, what your actions would be. And then if you have any issues beyond that, I can put our branch mailbox in the chat, and you are free to send any concerns, inquiries you have. And I have liaisons in my branch that communicate with each MCO to help rectify any issues that you guys are having.
Chelsea, can I ask a couple questions on that?
Sure, yeah.
So is there some way for us to know if the eligibility was lost or shouldn't have been in place due to the SSI? Is there some explanation somewhere? Because, the frustration that we run into is we do all the steps. I have an entire employee just to check eligibility every day. They're eligible. And then we find out later that there's a recoupment because they weren't. We have absolutely no way to determine what's going on behind the scenes. We can only do so much, and we have a high volume practice. So, it's one of those things where I don't even know how we would know that it was from SSI that they became disqualified retroactively versus some other source. And if you could just give I know you have a list, but like a brief synopsis of what that process will look like.
Yeah, absolutely. And I just want to check real quick to make sure Justin doesn't have a comment to make before I share.
No, I'll let you share. I'm sorry. Go ahead.
Okay. No, there's no problem, Justin. Aaron, do you mind if I share screen real quick? It might be easier to
Sure.
kind of have a visual.
Let me have a second. There you go.
Thank you so much. All right. Are you all able to see this here?
Yes, ma'am.
Okay, perfect. So yes, to answer your question, you definitely would not be able to see why the change occurred. So part of the process that the eligibility team has developed is if you have a case where you're getting a recoupment and you check the eligibility, you confirm that the MCO reassignment or removal occurred. You can send that information to this branch email box here, and they will review and determine if the eligibility reassignment was due to SSI. And if it was, then we will help facilitate you to discuss with the MCO to ensure that you are made whole from that process, or that the recoupment doesn't happen.
Thank you.
Yeah, of course.
And Jordan has been able to join us. So.
Oh, okay. Great.
Jordan, the current conversation is Dr. Colosso was asking if they got a recoupment letter. How do you know that it was due to SSI? And Chelsea was showing the document that you guys had created. And I wasn't sure if there was anything else you would like to add or share on that topic.
So I would just say if you receive a recoupment letter to just go ahead and reach out to the eligibility inbox so we can take a look. We don't expect that you all would know whether or not there was a retroactive change in eligibility. I think that's on us to kind of figure that out. And so if you all get a recoupment letter and it seems like maybe like you all know that that person had that managed care organization at that time, and something has happened, just send it on in so we can review it. That would be your best bet. And we don't want to put the the onus on you all to know the difference between a correct change and an incorrect change. So that's what I would say.
And I know you guys are hitting SSI. However, does that seem to be the main issue? Or does that, I mean, obviously as providers, we won't know, but does that appear to be the main issue from what you guys are able to determine? It's mostly SSI
It
when this is
is.
occurring?
Yeah, it is because we wouldn't normally expect a case's eligibility to change that far back. And so the current system functionality is that retroactive SSI Medicaid is always issued as fee for service, regardless of whether the person may have had managed care for however long that Medicaid is going back. So we have a system change in process. I think it's supposed to go in October to prevent this from happening so that when people are issued retroactive SSI coverage, the system can determine if they had, excuse me, a managed care organization or not. Sorry about that. But yeah, it is mostly the case that it is a retroactive SSI because it can go back and change eligibility for, however many years. Whatever SSA determines the disability start date is when their Medicaid would begin. So.
Any other clarifications from the MCOs or other state? I know Mr. Derringer had his hand raised for a second.
No, I think they covered everything I was going to say.
Okay.
BJ, I'm glad that you followed up on if it is wholly or nearly all an SSI issue. I've been contacted by the KDA direct, which they've been getting calls. So I'm hoping that it is just SSI and that will be resolved with the new system. But it appears that this is quite a few, all affecting all general dentists, specialists, all. And so I wonder if it's all SSI, but I don't. As you pointed out, providers have no way of knowing why the change occurred, just that a recruitment occurs.
Yeah, and I can address why this has kind of become a large issue as of recent. It's because SSA has been doing a catch up on their backlog of disability determinations. And so we're seeing a lot more of this come up, whereas it may have been kind of a rare occurrence before, or at least not at this rate. But yeah, definitely, if you all ever have any kind of question on a recoupment letter, please just reach out to us. We're happy to look into it and facilitate resolution with the MCOs for you all.
Thank you.
Okay. Any other new business that needs to be addressed or further discussion? Any TAC members? I'm sorry, I have screen share up, so I can't see hands or anything. See if it will. There we go. If no other new business, is there any other general discussion or questions that we need to address or from the attendees? No. Any recommendations that need to come out of this going forward to MAC consideration, or do we need to have potentially more discussion to draft a formal recommendation?
I would say we need more discussion for a formal recommendation. I would comment though that just from my experience thus far with the MOAB, and from the legislators that are involved with it, they are serious about helping and fixing dentistry, and they're serious about the money that was not that was earmarked for dentistry that did not make its way to dentistry previously, and our actions with the TAC, and then specifically with what is going through with the MAC, are they're looking to hear our voices. So I appreciate everyone's efforts and look forward to what we do bring forward, and then making this network better for all of the patients and the providers, and for those that are running it. So thank you all for your help.
Well, if there is no other business to be discussed right now, is there a motion to adjourn?
I can make a motion.
Dr. Clausen makes motion. Is there a second?
Second.
Motion being accepted for adjournment. Everyone have a good weekend.
Thank you.
Thank you.
Thank you.
Have a great weekend, everyone.
Take care.